you're welcome to turn your camera off. And I think everyone knows by now, but we want to try to keep our microphones muted when we're not speaking, so it cuts back on any background noise. I'm Rachel Porter, class of '06. Hello, I work at Wells in the alumni and alumni engagement office and advancement. And people are still trickling in, which is great. Yeah, so I'm super excited to be here tonight with you all. And I'm going to give a quick intro to our speakers. And I'm also going to just give a quick Cayuga land acknowledgement. So the college passed this, the faculty approved it in May of 2018. And they say this at the events on campus now. So Wells College recognizes our collective responsibility to acknowledge our colonial history. This land is the traditional land of the Cayuga Nation, a member of the Haudenosaunee Confederacy. Wells College commits itself to ensuring the traditions and cultures of Indigenous peoples are embraced and reflected upon in order to engage in solidarity with the Cayuga Nation. So tonight we've got two really great speakers. They are going to really tie in together, you'll see. And we're going to start with Sarah Heppner, class of 2005. She is, oops, sorry, I'm also managing the waiting room. So Sarah is the Director of Policy and Research in the Federal Office of Rural Health Policy, located in the U.S. Department of Health and Human Services. She has been with 4HP since 2012, and prior to becoming the PRD director, she served as deputy director of 4HP's Office for the Advancement of Telehealth. Her professional interests include using health services to understand the impact of policies on access to care in rural communities and rural health disparities. She holds a Master of Science in Clinical and Translational Sciences from the University of Vermont and received her chemistry degree from Wells College. And then Sue Trainor, class of '85, will be our second portion. And she has been a nurse for over 30 years, working since 2010 as a nurse practitioner. She studied philosophy at Wells with the intention of working in retail in New York City after graduation. She found her way into nursing through the ASN program at Tompkins. Oh, sorry, this just like skipped me out of my blurb here. Tompkins Portland Community College. Currently, she works for Mount Nittany Health in Central Pennsylvania, and she specializes in caring for patients with diabetes and associated metabolic disorders. And she's also the clinical coordinator for outpatient diabetes education services. She's certified in diabetes education and mentors upcoming diabetes educators, and is a member of the Provider Outreach Work Group for the Certification Board for Diabetes Education. She serves her community by chairing the YMCA Advisory Board of the State College YMCA, and she also loves to bake bread and stays active working out at Orange Theory. So we're going to do a brief presentation from each alum, and they'll have some time for Q&As. And we will also have this as a recording, like I said, on the Wells College YouTube page in the next day or so. If you want to connect with either person, just send me an email at the alumoffice@wells.edu, or give us a call and we can help make a connection. So I'm really excited. Thanks for being here. And I'm going to turn it over to Sarah.
Great. And Rachel, can we do a quick tech check? Can everyone see my regular presentation slides and hear me okay? Great.
Yes.
So the first thing that I have to do is share the disclaimer. I am tonight not speaking in an official capacity. The information, conclusions, and opinions expressed are mine, and no endorsement by the Federal Office of Rural Health Policy, the Health Resources and Services Administration, or the Department of Health and Human Services is intended or should be inferred. As Rachel mentioned, my name is Sarah Heppner, for those of you who don't know me, and I am the Director of Policy and Research for the Federal Office of Rural Health Policy. One thing that isn't in my official bio, but that I love to share is that I started out my federal career as an unpaid intern in the division that I now run. And I knew from my time at Wells the value of experiential learning. And so I made sure that my course progression in graduate school included a practicum component. It's a weird day if I have to call on my chemistry degree in my current job, but the broader skills that I learned as a Wells student, like how to communicate clearly, how to problem solve, how to build coalitions, how to craft convincing arguments, especially the argument piece, I use every day. And today I'm going to provide a high-level overview of the health status and healthcare infrastructure in rural communities before the COVID-19 pandemic, so that we can better understand the context in which rural healthcare providers are working to combat the pandemic. And then more importantly, I'm going to turn things over to my new best friend, Sue, to talk about her experiences as an actual healthcare provider, because at the end of the day, it's really the people who are on the front lines providing care or receiving care who I think folks really need to hear from to understand what's happening in rural communities right now with COVID-19. So the first thing that I want to do is just set the rural context. As you can imagine, and actually I just realized, is this weird bar showing up across the middle of the map, or is that not being
Nope,
shared?
it looks good.
All right, awesome, okay. So everything that's blue on this map is rural, and that's a lot of land mass. 86% of the land area in the country is considered rural, and it accounts for about 20% of the US population, or 60.8 million people. One of the biggest misconceptions is that all rural communities are the same, or that rural communities are just like miniature versions of urban communities that are spread out over a larger land mass. And as we're talking tonight, you might hear me share a fact or a narrative that doesn't match your personal experiences living or working in rural communities. And you're probably right. When we start looking at rural communities at the national level, we obscure the community characteristics that make each rural area unique, both the things that act as protective factors and things that can sometimes be challenges for rural communities as well. But there's some really important trends and common themes for rural communities that have made rural as a whole particularly vulnerable to the COVID-19 pandemic, and that's what I want to focus on tonight. Rural residents are on average older, sicker, and poorer, frankly, than their urban counterparts. People in rural areas live 3 fewer years than people in urban areas, and they have higher rates of tobacco use, physical inactivity, obesity, diabetes, blood pressure, a whole range of health issues they're more likely to have in rural communities. And I mention this because we know that older adults are more likely to become severely ill from COVID-19. According to the CDC, more than 81% of the COVID-19 deaths occur in people over the age of 65. We also know that the risk of severe COVID-19 increases as the number of underlying medical conditions in a person increases. Long-standing systemic health and social inequities have put various groups of people at increased risk for getting sick and dying from COVID-19, including many people from racial and ethnic minority groups and people with disabilities. So, for example, studies have shown that people from racial and ethnic minority groups are more likely to have increased COVID-19 disease severity upon admission to the hospital than non-Hispanic white people, and that they're also dying from COVID-19 at younger ages. And we could have a whole separate Learning by the Lake series just talking about health inequities, but I wanted to make sure that that is also part of the framework in how we're thinking about this. Although there's a common misconception that rural equals white, we know that rural areas are becoming increasingly more diverse. According to 2020 census data, about 1 in 4 people living in a rural community identify as a person of color, but we also know that the demographic diversity varies considerably from place to place, with rural counties that are in the South and in the West being particularly racially and ethnically diverse. These systematic inequalities build on one another and are an important part of understanding the impact of COVID-19 in rural communities. Lastly, I also think it's important to note that rural populations are more likely to be uninsured and have fewer affordable health insurance options than people that are living in urban and suburban areas. I think it's also important to understand access to care or challenges to access to care in rural populations, and that comes from both the provider and the patient challenges. I'm only going to very, very briefly talk about this because Sue is absolutely the expert on this call from this perspective. But what you're seeing in this map right now is what we call the rural healthcare safety net. And we know that it's important to understand the healthcare infrastructure in rural communities when you're thinking about access to care and people being able to be treated for diseases like COVID-19. So the critical access hospitals are the pink dots in this map. Rural health clinics are the blue dots, and federally qualified health centers are the green dots. And the reason why we focus on these three providers is that they have special payment designations from CMS, the Centers for Medicare and Medicaid Services, to increase their financial viability given the populations that they serve and the low volume environments in which they operate. So basically, we as a society have decided that these providers need to get access to more money so that they can keep their doors open, so that that 20% of the country can have access to a hospital or have access to a primary care provider, because from a financial standpoint, they're not likely to do so without those supports. And that's why we call them the safety net providers. But even with this, we know that rural residents have longer distances and longer travel times to care than their urban counterparts, and that there are fewer providers per capita in rural communities than in urban communities. We also know that heading into the pandemic, rural hospitals only had about 20 or 30 days cash on hand. And cash on hand, for those of you who may not know, is an estimate of the number of days that an organization, in this case a hospital, could operate if no cash were to be collected or received. And this is really important to note because acute care hospitals, if you guys remember back in 2020, were canceling elective procedures and some routine care to ensure capacity for COVID-19 patients. And because rural hospitals had less cash on hand, they were more vulnerable heading into the pandemic than their urban hospital counterparts from a financial perspective. So it became a very concerning potential circle in the idea of you're canceling the things that cause you to make money with the idea that you need to make sure that you have capacity to treat COVID-19 patients. But without those services, you might not be able to keep your doors open when the pandemic hits your doorstep. And this was the driver behind the first cash payments from the Department of Health and Human Services to vulnerable hospitals to ensure that those hospitals were able to keep their doors open, and subsequent payments to the healthcare providers through the Provider Relief Fund. So now I want to talk a little bit about COVID-19 case and death rates. And all I really want to do to draw your attention on this slide is see those green lines that are up at the top and showing that they look worse than everybody else. That's rural. Those are rural communities. And that's what we're seeing right now at this stage in the pandemic. Mm-hmm. So looking at the cumulative COVID-19 case rate, we know that in September 2020, the COVID-19 incidence rate, which is the cases per 100,000 people in rural counties, surpassed that of urban counties. So although the trajectory is similar between urban and rural counties, you can see that rural counties are trending higher than urban counties in the last several months in a much more dramatic fashion. As of December 7th, I believe was the date that I pulled this data, the cumulative case rate in rural communities was 16,515 cases. Oops, I think I have my, oh no, I'm good. 16,515 cases per 100,000 people. And in urban communities, it was 14,596. So now looking at the death rate, which is an unfortunate part of the conversation as well when we're talking about the COVID-19 pandemic. In December of 2020, so a little bit later than what we saw with the case rate, the cumulative COVID-19 death rate in rural areas surpassed that of urban areas, and that's remained true ever since. So you can see the death rate in rural communities is just shy of 300. It's 296.11, and in urban areas, it's 229.13. So the next big question, of course, is, well, what about all these vaccines? So the take-home message here is that the vaccination rates decrease as rurality increases. The more rural you get, the less likely you are to be walking the streets with people who are vaccinated. And this really goes back to the beginning of the COVID-19 vaccine availability. Rural residents have been more vaccine hesitant, and this has continued to play out throughout 2021. And the other important piece of this is that the reality is when vaccine supply was incredibly limited, when vaccines first became available, by and large, we weren't seeing a lot of vaccine being distributed to smaller, more remote rural communities. They were really going to, where the states and jurisdictions were really directing them to where they felt they could get the biggest bang for their buck and just not waste a single drop of vaccine. And the reality is that's not likely to be in a rural community. And so disparities in COVID-19 vaccination access and coverage between rural and urban communities has been persistent. And the reality is this can hinder progress towards ending the pandemic.
Mhm.
So one of the things that we know is that, when it comes to reaching rural residents and trying to tackle that vaccine hesitancy, a large majority of rural Americans, about 86%, say that they trust their own doctor or healthcare provider to provide reliable information about the COVID-19 vaccine. And so capitalizing on that fact, the team that I led has been able to quickly get several programs started to get funding and vaccines to rural communities through CMS certified rural health clinics, which, as we discussed earlier, are an integral part of the rural healthcare safety net. And they're specifically located in rural and underserved communities. So just because you're rural doesn't mean that you can have a rural health clinic. You have to be rural and you have to be an underserved area from a healthcare perspective. So the first program that we developed focused on testing and then testing and mitigation efforts once we got into year 2 of the program. We, at that point, were working with over 4,500 rural health clinics to ensure that they had financial resources and technical assistance necessary to maintain and hopefully increase access to COVID-19 testing in their communities, and also to support a range of mitigation activities. So mitigation activities can, make sense, but maybe not be tangible to everyone. So those are things that are actions that people in communities can take to slow the spread of the pandemic. So for example, case investigation, contact tracing, promoting and building confidence in COVID-19 testing, that's a big one. Why should you go get the test? Why is it important to go get the test? Community education, and also things like building or constructing of temporary structures or retrofitting rural health clinics to make sure that their physical structure could follow COVID-19 best practices. And the main goal was to make sure that rural health clinics knew that they could use the money for supplies, for workforce, really for anything that they felt that their communities needed, and to have access to the widest range of allowable activities possible. Because as I said earlier in the presentation, there's huge variation and variability in rural communities. And what works in one rural community is going to be a total flop in another one. And the people who know best and who knew best at the time and how to make sure that they were doing effective and important work in their communities was those rural healthcare providers. It didn't make sense for us to be sitting on the East Coast in DC saying, these are the things you should do. Our job was really to make sure that we opened the door as wide as possible to say, okay, we're going to send you some money and we're going to give you some technical assistance, and you have to tell us what your community needs, and we're going to have program accountability to make sure that what your community needs is something related to COVID-19, but really making sure that rural healthcare providers were motivated and trusted and incentivized to do the work that they needed for their individual communities. And the technical assistance support was and continues to be so vital, because rural health clinics are not typically large organizations. It's a nurse practitioner, maybe an MD or a DO. It's maybe someone who runs the front desk. Rural health clinics aren't required to be open every day of the week. Rural health clinics are not required to be open all day long. These are limited resource facilities. And so we really had to provide technical assistance to them to make sure that all they had to do was provide care and tell us what their communities needed. The second part of the approach that we took was to provide grant funding and technical assistance for rural health clinics to promote vaccine confidence in their communities. And we had 1,975 rural health clinics who applied for that funding and signed up for us. Many of these rural health clinics had never applied to a federal grant before. They had never gone through this headache of a system that we had no control how to change. And so the folks that I work with, my team, were incredible. They were manning the phones well into the night. They were answering emails all night long, because these providers, they don't have ample amounts of time, right? Sue, I'm sure, is going to talk about this, to sit down in the middle of the day and chat with someone about how to get their grant application in. So we made sure that we were answering emails at night. We were providing multiple technical assistance webinars and had partners across the country who understood the regional variations and who could provide that technical assistance to make sure that folks could get their applications in. And then once we gave them the money, their reality is there's a little bit of red tape wrapped up in getting money from the government. And so also making sure that we could hold their hand and guide them all the way through that process as well, and make sure that they knew how not to accidentally run afoul of the rules for receiving money, and make sure that, again, all they had to do was act as trusted messengers and to do the work that they felt like they needed to do for their communities. And again, this was really wanting to capitalize on the idea of local primary care providers as trusted messengers, and to ensure that rural health clinics have the resources they need. So they have been working to create education campaigns. They have been able to hire extra staff to provide counseling and information about vaccines, because we were hearing from rural health clinics that appointment times were getting extended. And again, I'm sure Sue is going to talk about this much more eloquently, but just making sure that there were folks who could take the time and have conversations as those trusted providers as their patients came in. And also doing community outreach events, really anything that would work for their communities, and making sure that the rural health clinics could brand it as their own work and not have it seem like the federal government was coming in to message or to influence what was going on, because that's not helpful in all rural communities. The last thing, as of the time that I was putting these slides together, but I have one other program that I can talk about as of today, really, was vaccine distribution. So going back to what I said earlier about how, at the start of vaccine availability, we really weren't seeing that states and jurisdictions were getting vaccines to these small healthcare providers, because they may not be able to use every dose in the vial. And there were, issues with the minimum number of doses that could be shipped. For Pfizer, they could ship 1,170 doses. That is an insane number of doses for a rural health clinic to receive when you think about the number of patients that they receive, how quickly the vaccine expires, the cold chain requirements. It's just things like that were really challenging for many rural health clinics. And so we came in and we were given an allocation of doses that we could work with rural health clinics to get them signed up, again, giving them technical assistance, because not all rural health clinics were ready to jump into all of the CDC requirements for being able to provide vaccines. So making sure that, again, we could package and help and remove as many barriers as we could to make sure that if someone wanted to get their vaccine from their local healthcare provider, rather than going to an urban area, going to a big mass vaccination event, going to the county health department, if those things didn't feel right for them, if those things were barriers for them, that we were able to use these local healthcare providers, and also not make it as burdensome on the local healthcare providers by wrapping around and trying to break down some of those barriers and saying, okay, well, we're going to find a way to get you a smaller number of doses, or we're going to find a way to help you use your testing and mitigation money to buy the type of cold storage you need for Pfizer, all of these different things. The other program that we are working on, and this is new, really even as of today, you may have heard that President Biden announced a week ago today that there was a new initiative to get over-the-counter test kits for COVID-19 out to federally qualified health centers and rural health clinics. So for the past week, I've been able to jump in and figure out how the heck we're going to do this. And so that's been really exciting, because what we've heard from our rural health clinics is that even though they could use their testing and mitigation money to purchase over-the-counter tests, they couldn't always find over-the-counter tests. And so being able to connect rural health clinics to over-the-counter test kits and make sure that they have a steady supply, they know that they're getting a test kit that's high quality, having that technical assistance connected with it. What we're hearing from our stakeholders is that they are super excited, and that this is something that they need for their communities. So we're continuing to, as the course of the pandemic changes, continuing to be able to get new programs up and running from our little office, because we're this voice for rural across the Department of Health and Human Services. And so we're able to carve out spaces and create programs that are specifically targeted to be able to help rural communities. The last thing that I want to share is that I mentioned I was an unpaid intern in my office. It turns out now you can be a paid intern in my office. And so I get to pick an intern to come work and get paid. And, you know, pre-pandemic be in DC, now it's a little funkier. But I would encourage, if this gets to any of the students who are in the Rural Healthcare Immersion Program, or, you know, otherwise interested in rural health policy, to reach out to me, because the application process is confusing and competitive, and it happens at the larger enterprise level, not just for the Federal Office of Rural Health Policy. But I can be a really good guide in helping to make sure that students understand how to get through the process, how to get their resumes set up, because federal resumes are weird and long and confusing and go against everything everyone has ever learned about how to put a resume together. And I would love to have a Wells student come be an intern in my office. So I'm going to pause there and see if anyone has any questions before I turn things over to Sue. But of course, you know, we can also do questions for both of us at the end after Sue has a chance to speak as well. Hi, Lisa.
Hi, it's wonderful to see everyone, and what a treat to hear from you and hear from Sue tonight. Two fabulous Wells graduates speaking about such an important topic. Sarah, as always, thank you for your work. You know, it is interesting to me always, as I've watched your leadership, to know how much you do, and you gave us that map that reminds us of the need to have more investment in rural healthcare, and yet the fact that it isn't there. So that's just, I know that on a daily basis, but I was pleased that you highlighted that. COVID is but yet another reminder to us, as you said, about disparities and about issues of underinvestment over time in communities, including in the healthcare communities. So what are you seeing? Are you seeing or able to share any of the sort of best innovations that are emerging as a result of the capacity building that you've invested in, both over time the past 2 years, but you've done incredible work, Sarah, guiding, you know, building innovation for sustained outreach and outcomes?
Sure. So that's a great question. And I think, you know, we've talked before about the overlap between the populations that you serve at AARP Foundation and, you know, knowing that rural isn't that older, sicker, poorer, right? Like we are right there with you in terms
right there
of,
at the center,
you know, what's going on and from the AARP perspective. And there's two things that I would share. And the first is that we have learned throughout some of the larger programs in our office. So in the Federal Office of Rural Health Policy, there's a series of divisions. From the divisions that are more focused on getting dollars out to communities and letting communities do innovative work in non-pandemic times, one of the things that we know that's absolutely key is the ability to build coalitions, because in rural communities, one organization may not have the ability to hire a full FTE for insert job here. But if you're able to build a coalition among other organizations, then one organization can chip in 10% of an FTE. Someone else can chip in 15% of an FTE. And you can look at things like increased purchasing power. You can look at things like community outreach and messaging, and how to make sure that what's happening at the local hospital is connected back to what's happening at you know, spiritual organizations that are in the community that are doing volunteer work. You can connect back to social services that are really important and connect back to those drivers of the social determinants of health. And when our office is able to provide seed money to help rural communities stop and plan and test and hopefully get outcomes and data that they can use to then share their story, they can share that to get larger grants for sustainability purposes. They can make the argument to health insurance and to other payers. They can then be set up to engage in models that are coming out of CMS or the centers for the CMMI, the Innovation Center at CMS, where they can then move from what was an idea to something that's actually sustainable. But what we know in these rural communities is that if they don't have that seed money, if they don't have someone that will help them take that year to plan and figure out how this is going to work, or take 3 years to do a pilot, to do a demonstration, they're never going to be able to get from the point of folks saying, here's an issue and I know we could solve it, but I have 10 hats that I'm wearing and there just aren't enough hours in the day for me to provide care to meet the immediate needs of the community and do long-term planning. And so that's a huge piece, is that coalition work to be able to figure out who are your partners and how can you leverage them to make sure that you're able to meet the broader needs of your community. The other thing, and I can't emphasize this enough, is that these decisions cannot be made from an urban area going into a rural area. They cannot be made from the federal government going out to rural communities. We strive, and in our authorizing legislation in as many places as possible, there are specific language inserts in our funding opportunities, in the way that we work with communities, where we say, you all are the experts, you have to tell us what you need in your community. And there's going to be some guardrails and things like that to make sure that, you know, we don't make our appropriators on the Hill upset, but we're going to make sure that we recognize that you all are the experts on what your communities need and how you can work with the resources that are in your communities to mitigate any barriers that may exist there.
Great. Appreciate your leadership on these important issues, Sarah.
Thank you.
Awesome. We did have a comment from Jenny as well, just in the comment section in the chat, just saying, way to go. You sound like a nonprofit leader who works for government to me. We need more out of the box and flexible thinking like you described.
Ah, shucks. Thank you. That's very sweet to say. All right, well, I think I'll turn things over to Sue, because I want to make sure that you guys all have time to hear about someone who's actually doing this work on the ground, which is so much cooler and so much more important. So I am going to stop sharing and turn things over.
All right, I'm going to share my screen and let me know, Rachel, are you seeing my screen? Are you getting what I want you to see at this point?
Not yet, but I know you can, I know you can do it.
I know I can do this. I know I can. Oh dear. Let's see.
Here we go. Yeah.
Are we there?
Yeah. Your presentation is up. We're ready to rock and roll.
Okay. Hi, everybody. I'm Susan Trainor, and I'm a Wells graduate. I graduated in 1985, and I actually started with the class of 1984. So I like to introduce myself as either being evenly odd or being oddly even. So I'm really grateful to be here tonight with all of you. I'm going to switch back. I'm not as technically proficient at PowerPoint and Zoom, so I'm going to step back and I got a little bit ahead of myself there. So I did want to mention that Una, my good friend from class of 85, has invited me here tonight, and I'm really quite glad to be here. We thought that my clinic experience, shared along with Sarah's experience working at that very high level, would provide a unique perspective for all of you tonight on the COVID pandemic. And in particular tonight, I'm going to share stories of 3 patients that I've worked with who have lived experiences during this pandemic. And they highlight some of the very real challenges that we face in healthcare today. I do want to tell you ahead of time that 2 of the 3 stories have what I think you would consider, you know, a happy resolution, but as in real life in the clinic every day, that's not the experience that everyone gets. I also want to share with you that in the interest of protecting the identities of my patients, I've changed the names and some of the key features of who they are. What hasn't changed is the circumstances of their stories nor those outcomes. And 2 of the 3 people that I'm sharing with you about tonight know that I'm sharing their stories with you in this way. I didn't have a formal disclaimer slide like Sarah did. I probably should. I'm here representing myself as a provider tonight, not my health system. So the main points I want to share tonight from, you know, that boots on the ground diabetes nurse practitioner perspective is how important it is to have a trusting relationship with patients in our community in order to provide the best possible care. Whether it's care for people with diabetes or care for those same people with diabetes now making decisions about things like getting vaccinated for COVID. So I think trust and community are the two key features I want to talk with you about tonight. I do want to talk a little bit about the healthcare system that we have now and how even pre-COVID pandemic, the diabetes epidemic that I've been working in now for over 18 years has been affected by the system and by all of us. And I also want to talk about how I think our healthcare system is struggling to meet people's needs. And in many cases, I have to say, I think we're failing our patients. I hope that tonight I can give you that sort of boots on the ground view and a feeling for what we're trying to take care of in terms of the people during this epidemic and what that can be like, and particularly how we struggle with chaos in our healthcare system. And I want to step back, maybe Lisa, some of the other people who are on today might remember this. Back in 1980, when I arrived on campus in Aurora, I was quite homesick. I'm from Long Island. I mentioned I was going to go into retail. And I went to convocation, and I had never been to a convocation. I didn't know what a convocation was. And I was sitting up in the balcony in the auditorium at McMillan, and I looked down and I saw all the professors coming in their academic robes and in their caps. And I was really kind of overwhelmed by the experience of all that. And President Peterson at the time said, you know, if something is going to get done at Wells, a woman is going to do that. And I was really struck in that moment. I had been feeling very homesick, and I realized I kind of looked around and I thought, boy, I am surrounded by people who think that I can do anything. And that had not been my experience before I got to Wells. And I've thought about what she said, you know, many, many times since, particularly when I'm getting in a jam and I'm starting to doubt myself. I think, you know, I'm a Wells woman and I'm going to get this done. So I'm really grateful for that. And it was one of those seminal experiences, one of those things I call that before and after experience. I also know, now this is a disclaimer, Randy and I talked about this before the talk. I know that this statement about Wells is outdated now, and it doesn't reflect the Wells community as we know it today. And I'm grateful that Wells has evolved over the years to become the community that it has, and that we've adapted to changing realities. And I hope the same for the healthcare system that I work in now, as we struggle with some of our changes. I want to go back very briefly. I'm not a healthcare historian, but I want to talk a little bit about how the healthcare system got to where we are, because over time, I've come to think that some of the problems that I'm dealing with in the clinic are unique to this time and this place, and it turns out they really aren't. And in terms of building a community for care, back in 1944, in his State of the Union address, President Roosevelt proposed a new Bill of Rights, and he talked about political rights as a way to develop policies and to challenge Congress to pass that legislation to support and protect fundamental rights, one of which he identified as the right to adequate medical care and the opportunity to achieve and enjoy good health. And while good health is defined differently for each of us, FDR's challenge to work as a community towards the goal of providing adequate medical care remains that challenge today, especially as we face these problems, the epidemic of diabetes and also the COVID pandemic. So building that concept of community is really important. And he challenged us to understand that we can't be content. None of us can be content in community so long as any one of us is ill-fed, ill-clothed, ill-housed, insecure, or sick in a way that might be preventable, or as Sarah said, that might be something we could mitigate about that problem. I know that in our bios, I didn't know we would read the bio tonight, but I just wanted to share briefly. I graduated from Wells in 1985, and I know we didn't have a BSN, a Baccalaureate of Nursing Science at Wells at the time. So it was a little unusual for a philosophy major to decide to go to nursing school. And I didn't really decide. I had a couple of really sort of interesting life experiences between 1985 and 1991, when I finally graduated from Tompkins Cortland Community College in Dryden. I worked for several years as an inpatient critical care nurse. I've also worked in emergency rooms. And then I also worked as an outpatient nurse educator in the clinic where I'm currently working since 2003. And then back in 2008, I went back to the Bloomsburg University here in Pennsylvania and got my master's degree in nursing in adult primary care and became an adult nurse practitioner. And I went back to the clinic where I'd been working as an educator and became an outpatient diabetes nurse practitioner, where I've been working since 2010. And as a side note, I also worked as the interim director of quality for our physician group when we first became a physician group in 2011. And that put me right in the middle of the healthcare delivery changes that were related to the implementation of the Affordable Care Act. So Sarah was talking about some of that in her talk. And that's really a talk for another time. I really don't want to get too far into that. But I do want to say that if you had told me back in September 1980 that I'd be doing what I'm doing today, I would have told you that you were crazy. But it turns out that being a philosophy major from Wales and a nurse practitioner is really not a bad way to go. I've had a really great experience doing the work that I'm doing. And this just ever so briefly, because I know we're going to be running out of time. And I want to get to my stories tonight. You know, basically, we've had this hot potato issue going back and forth, and this has a lot to do with national health insurance. And I'm not going to, you know, have the argument tonight about whether or not we should have national health insurance. But, you know, FDR was, you know, arguing for a national health insurance program back in the 1930s and the 1940s as part of his New Deal platform. And then in the 1960s, we had the Great Society. Lyndon Johnson was able to amend Medicare and Medicaid as amendments to the Social Security Act that FDR had signed in 1935. Of course, in the 1980s, we had cost containment. So it's a little bit like a game of whack-a-mole. No sooner do we make some progress than we actually have some pushback. And we've been experiencing that a lot in healthcare recently. In the 1990s, another push for healthcare reform that wasn't necessarily very successful. And that brought us to the 2010s, the Affordable Care Act, also known as Obamacare. And so these have all been changes that have been impacting the health system. And, you know, I realized that it wasn't just my struggle and it wasn't just this particular time. What we've all been trying to do all along is to try and help people get to their best possible state of health using the healthcare system and trying to open access and build communities to help people get what they need out of a healthcare system. I do want to shift gears here. I did talk a little bit with Rachel the other day about diabetes, and since that's what I do and I've been doing now for quite some time, I do want to share. We've been dealing with an epidemic of diabetes prior to the pandemic, and that's had a great impact on the healthcare system as well. Currently, or the most current statistics we have in 2018, 1 in 10 Americans have diabetes. And actually 1 out of every 3 people living with diabetes doesn't know they have it. So we have quite a few people living with a disease that has preventable problems, and we're not treating that disease. More importantly, 1 in 3 people living in the US right now have prediabetes. And prediabetes is a condition of abnormal blood sugars that isn't high enough to be diagnosed as diabetes, but left untreated and left uncared for, it can progress to type 2 diabetes within 5 years. And one other thing I wanted to say about diabetes, we know that 1 in 4 people over the age of 65, so coming back to what Sarah was saying, older people living in rural communities are also people living with more chronic disease. So the population of people living in those rural communities are much higher risk for developing severe COVID, as Sarah mentioned. And then in addition to all this, one of the major concerns that we have right now is that based on all the statistics that we have, according to the CDC, 1 in 3 children born in 2000 will have diabetes. I'd like to talk a little bit about the experience of what living with diabetes is like for my patients. Living with diabetes is like having another full-time job for most people. And most of my patients forgot to put nursing or medical school on their to-do list. So they don't come to their disease well prepared to manage the disease. We have fewer and fewer providers. I'll talk about this in a couple of minutes. And providers are what are needed to be able to help people learn what they need to learn to manage this chronic disease and to avoid the preventable problems of diabetes. In terms of how we're working in the healthcare system, right now we deal with an administrative focus on productivity, which means we're being asked to see more and more people with less and less time. And coming back to that concept of community and trust, it's very difficult to build relationships of trust with people and to build a community of care when we're being pushed to do more and more with less and less, particularly with time. And at the same time, on the other side, we're facing our payers, insurance. And insurances are usually, the insurance payers are typically focused on controlling cost. So at the same time that we're trying to, provide the best possible care, take time and build relationships of trust, we're dealing with these two things squeezing us in the middle, making it harder and harder to provide the best possible care, going back to what President Roosevelt challenged us to do. I do also want to talk a little bit about the overall cost of diabetes, and these statistics come to us before the pandemic. In 2017, the 1 in 7 US healthcare dollars was actually spent on diabetes. And we know now that more than 50% of those dollars are spent on diabetes-related hospitalizations and treatments of diabetes complications. Unfortunately, these are all problems that are related to getting inadequate care in the early stages of the disease, related to getting appropriate treatment and getting education. And right now, 12% of those dollars are spent on provider visits. So the place where the education is going to happen and the place where, we're going to be able to provide the best possible clinical care, we're only getting 12% of those 1 in 7 dollars to support that activity. We also talk a lot about the indirect cost of people living with diabetes. We see things like work absenteeism, disability from preventable problems. The most important cost of living with diabetes, though, for me as a healthcare provider, is the actual personal pain and suffering. I see this in my clinic every day as I try to work with patients who are dealing with less health insurance coverage, dealing with all kinds of problems, getting prescriptions, getting testing supplies, getting appointments with people like me. These are all things that are contributing to really, impacting the quality of life for people I want to provide the best possible care for. So in the clinic, one of the problems we have in diabetes is we have a critical shortage of endocrinologists. Sarah was talking a little bit about the, safety net. Just in terms of endocrinologists and physicians that are trained to take care of people who have diabetes and other hormone disorders, we have far fewer endocrinologists than we have any other specialty in the United States right now. Right now, we have 1 ER physician for every 7,000 patients. We have 1 cardiologist for every 14,000 patients. So probably, getting a new patient appointment with a cardiologist, depending on the area you're in, particularly in our area, might take about a month. A wait to see an ER physician might be 2 to 4 hours, although right now with COVID, it can be quite a bit longer than that. A hospitalist, we have about 1 trained hospitalist for every 25,000 people, but not everybody needs a hospitalist. And we currently have 1 endocrinologist for every almost 42,000 people with diabetes or other endocrine disorders. So for someone like me working as what we call an APC, an advanced practice clinician or a mid-level provider, there's an opportunity to move into that space and to provide care where we don't have enough physician providers. I want to tie COVID and diabetes together. Sarah talked a little bit about this before, but people with type 2 diabetes, so 1 in 10 people have diabetes, 90% of the people who live with diabetes have type 2 diabetes, are very high risk to progress to severe COVID disease if they're infected with the virus. We know that the different vaccines that we have, Pfizer, Moderna, Johnson & Johnson, have been shown to variously effective at preventing COVID-19 infection, but they don't all prevent COVID-19 infection. What the vaccines do provide for most of my patients, they will reduce the progression to moderate or severe COVID disease when someone is infected with the virus. So one of the challenges that I've been facing now in the clinic for over 2 years is not just helping people manage their diabetes under increasingly difficult circumstances with less insurance coverage and less access to providers, but also how do I start having the conversation with people about vaccines? So I wanted to this is the one slide that has a couple of images on it for you. So this is a photo I took. These are 2 photos I took last Friday when I went to work in one of the rural communities where I work twice a month. So when I'm standing in the corner of the parking lot, and I turn to the one side and I get a photograph of a hitching post inside the shed where people can park their horses when they come to the clinic in their horse and buggy. And then when I turn around, I'm looking at the parking lot where people are parking their cars early in the morning, trying to get in early in the morning so they can get their day started. So I do work in a rural community, and I also work in a central location where I take care of people who come into the central location from rural communities. In my clinic where I'm working in central Pennsylvania, we have 1 full-time and 1 part-time endocrinologist. We have 3 advanced practice clinicians. There's me and there's 2 physician assistants. We have devoted nursing and clinical staff. In the last 2 years under pandemic conditions, we've hardly missed a day. Within a week into lockdown, when we weren't seeing patients in the office, we were all in the office making calls to all our patients as if we had a clinic schedule that day. And we made sure that people were getting what they needed, particularly in the early days with lockdown. And as I mentioned, I work in a health system that's associated with a 200-bed hospital. We have 1 large central clinic located in our central town state college, and then we have satellite clinics in these rural communities. So I'm going to talk a little bit now. I'm going to switch gears. I'm going to talk about 3 of the patients. I said I was going to share 3 stories. I'm going to tell you a little bit about the patient. I'm going to talk a little bit about some of the barriers that that particular patient is dealing with. And then I'm going to talk a little bit about how things turned out for that patient. The first person I want to talk about tonight is Lori. She's 49 years old, and Lori is a stay-at-home mother of 3. She has 2 children of her own, and she and her husband adopted a 12-year-old girl a couple of years ago when that young woman who has disabilities, her family situation fell apart. So she has 3 children at home, and she was diagnosed with type 2 diabetes in 2011. She had years of struggle with her diabetes. She was in and out of the clinic, didn't come very frequently, and really didn't want to deal with her diabetes. But by 2019, she was coming regularly and she was finally getting it. Things were starting to come together for her. But then in March of 2020, her husband lost his job and he lost the family's insurance coverage right in the first month of lockdown because he worked in sales. And I talked to her early on in the pandemic about what would she do if and when a vaccine was available. And neither she nor her husband were particularly interested in the idea of vaccination. They had a lot of concerns and a lot of fear. So, you know, some of the problems that Lori and her family dealt with were, you know, related to not having insurance. So this is where the clinic I work in is just terrific. The nurses jumped in, you know, we tried to figure out what could we do to help some of our patients who were losing jobs and losing employer-based insurance. We did things like we changed Lori's prescriptions from 30 days to 90 days. So she would have adequate medications going into, you know, a period of time when she might not have health insurance. We taught her how to use the healthcare portal. So she would have access to her own electronic health record. And she would be able to take that record with her if she went to another healthcare provider, say a clinic where she might get subsidized healthcare. We delivered care to Lori for several months with phone calls and portal messages. Now we get paid to provide medical service and face-to-face encounters. So these were not services that were generating revenue for my system, but these were services that were critical to Lori and her family during this time when they had no health insurance. And we also provided referrals to county agencies to help her explore opportunities for getting insurance without having employer-based insurance plan. So some of the problems are most of us have an employer-based insurance plan, and during a pandemic, if we lose our jobs, we're going to lose our insurance at the same time. So there's a double whammy there. In addition, she was dealing with things like COBRA, the cost of actually COBRAing her insurance. So picking up the cost of that employer-based insurance is prohibitively expensive for her family, and it wasn't something that she could do. The out-of-pocket cost for an office visit is prohibitive. About a half hour of time with me, if you're paying out of pocket, is probably about $300 or $400. And then patients without insurance fall out of the system. And in Lori's case, she's a young woman with diabetes who had struggled for years and she was just starting to get it. So this was not the time that she needed to fall out of the system. So what happened to Lori? You know, she's a very resourceful woman. By June of 2020, she had her 2 children on the CHIP insurance, the Children's Health Insurance Program, and she had her 3rd child on Medicare for disabilities. And in July, she and her husband had signed up for healthcare exchange insurance plans that were available as a result of the Affordable Care Act. And by October of 2021, she had a new job. She got a job working for our local university. She now has the best insurance in the area. So she's got great coverage. She's doing better than she ever has. She's on her best treatment plan. And in June of 2021, both Lori and her husband did get vaccinated. We had the COVID vaccine talk, and she did get vaccinated, and they're doing well. And I think really importantly, her whole family sees her as their pandemic healthcare hero. And this is something that, we didn't expect would happen for Lori, but she's doing quite well. The next patient I want to talk about is a gentleman named John. John was 73 in January of 2021, so about a year ago. He'd been married for decades. He was actually married to his high school sweetheart, and they lived in the same community they both grew up in. He loved his wife, he loved his family very much, and he had been diagnosed with this type 2 diabetes in 1996. He's a retired truck driver, and he came in to see me every 3 months. He'd been coming since 2011 when I finished my program. And he didn't really have to come and see me every 2 months. He's very well controlled, did very well with his diabetes, but he was always wanting to do better. He was very, very proactive about his health. And we developed a very, close and trusting relationship. I saw him 4 times a year, and I got to know a lot about him and his family, and also about his vision, his dreams, the kinds of things he wanted to do. He was also a proud and distinguished veteran of the Vietnam War. He was decorated for his service. He was an active member of the local VFW. He's a community volunteer. He served the families of people who served in the armed services. John was adamantly opposed to the Affordable Care Act. He did not like Obamacare. We had the conversation a couple of years in, and that was a conversation that we agreed we wouldn't have again. I don't like it when politics comes into the exam room, but occasionally it does. So that's a delicate conversation to have. Again, that relationship of trust and being in community. But in January of 2021, as we were getting ready to start rolling out the vaccine, I did bring up the idea of vaccination with John, and he was adamantly opposed to getting vaccinated. We finished the visit, and we finished the visit on good terms, and he was planning to come back and see me in April for his next visit with me, his every 3-month visit. So some of the barriers, I'll go through this quickly. Sarah already touched on this. He was a member of a rural community. One of the definitions of rural community is less than 500 people per square mile. In our region, where we have the hospital and where my central clinic is, we have 1,000 people per square mile, and that includes some of the students at our local university. Our county seat, about 15 miles away, has about 249 people per square mile. But Johnstown, just only about another 5-6 miles out from that, the county center has 79 people per square mile. And John was actually living on the farm he had grown up on. The community age, going back to what Sarah said, we know that rural residents are older. In my area, State College, about 10% of our population are over 65. In our county seat, 14% are over 65. So technically our county seat is also a rural community, but doesn't have quite that same feel. In Johnstown, more than 1 in 4 people are over the age of 65. So, in his community, there's a much higher prevalence of diabetes, of chronic diseases, and also there's a lot more vaccine resistance, and also a lot more resistance to wearing masks and social distancing. John's wife and some of his family were vaccinated in early spring of 2021, and John did decline vaccination at that time. He called me. He had a positive COVID test in mid-March. And unfortunately, and I'm sad to say, John died of his COVID-related pneumonia in April of 2021, much earlier than he had expected to do so. So, despite the fact that I was able to create a very trusting relationship with him and to actually work in his community, I think Sarah alluded to some of this in her talk, we are still struggling to get the message out to people. But I do want to talk, my last patient tonight, I'll share with you and then we'll be done. The last person I want to talk to you tonight is Kelsey. Kelsey's 21 years old. Kelsey loves her fiance, Montana, and Montana loves her very much, and they're planning to be married in about 2 years. Kelsey was diagnosed with type 1 diabetes in December of 2020, so a year ago. Kelsey loves horses. She lives in one of the rural communities. And she lives with her fiance and his grandparents on their horse farm. So when she moved in with them, and she brought her horses with her. So she loves living on that horse farm with them. Her fiance and his family are anti-vaxxers. They're adamantly anti-vaccination. So Kelsey is the third generation in her family to have type 1 diabetes, and all three generations of her family are treated in our clinic, her father as well as her grandmother. So we have a long-standing relationship with this family, goes back more than 20 years with her father. She was diagnosed by her primary care provider with type 2 diabetes. And unfortunately, that wasn't the right diagnosis, but she was misdiagnosed because she's obese. Her father knew what was going on, and he called asking to bypass our wait list. We have about a 4 to 6 month wait list for a new patient appointment. So we were able to get her in very quickly, and I was able to see her within a few weeks of her diagnosis. I had a couple of visits with Kelsey over the next few months, and got to help her out, and always referencing her parents or her grandmother. So, pretty deeply embedded in her community. On the third visit that I had with her last spring, as she was getting ready to leave, she kind of turned around and looked at me, and she had that look on her face that I've come to know. And she said, I have a question. Could I ask you one more question? And I knew we were going to have the vaccine talk. So I said, yep, come on back in. And we sat down, and I asked her to tell me, what did she know about the vaccine? She wanted to know what I thought, but I wanted to hear what she thought about the vaccine before I gave her my opinion. She told me that she was afraid the shot would make her sterile. That was something that her fiance had told her about. She was also very afraid that if she got the vaccine, that her fiance or his grandparents would become angry with her and she would be asked to leave the farm. She said that she was afraid of getting sick. She was afraid of getting sick from the vaccine. And she said she really didn't know what to think anymore. Some of the barriers that she faced are access, but because she had a family relationship with the clinic, she was able to overcome that access barrier. We do fee-for-service billing, so more patients, more revenue. I talked about this earlier. It's very difficult to create a relationship of trust when I'm trying to see 15 patients in a clinic on any given day. If I see more patients, I'm going to have less time with them unless I extend my visits and I show up late for every appointment, which some people who see me know that can happen on occasion. The average length of time for a visit with a medical provider right now is down to about 20 minutes, which is not enough time to cover all the kinds of questions and issues that people have. And in 2020, 53 patients surveyed in a state survey reported leaving a scheduled visit with a provider because the wait was too long. This doesn't typically happen in our clinic because people wait a long time to come see us, but it does happen. So what I want to say about Kelsey is in October, Kelsey did wind up getting the Johnson & Johnson vaccine. One of the things I talked to her about was maybe not talking with her fiance and his family about getting vaccinated, and also getting the Johnson & Johnson vaccination so she could get a one and done kind of vaccination. She did wind up, I didn't know she was planning to do it, but on a Saturday morning, I got a portal message from her and she said, "I hope you're happy, Susan." She said, "I'm vaccinated now and I'm sick from that vaccine." And after my experience in the clinic taking care of people like John and other people, I replied back and I said to her, Kelsey, I am happy. I really am. So that's what I have. I know we've run a little bit over on time. I just want to say thank you all again for giving me your time tonight. I wanted to just let you know that I try to support WELS, and if you're interested in supporting WELS, there's opportunities to do that. This is a great picture. I lived in Maine for 3 years and loved living there. So I'll leave the talk at that. If you have any questions, I'm open for questions now.
We have one comment. Thank you, Sue. I'm sorry. I'm so excited. Yeah, thank you for speaking with us. I just want to help in the chat just in case you don't see something. We've got a couple comments there. Judith said, I worked on the business side of healthcare for 12 years, and this so resonates with me. This could be a whole other talk. Sarah said it really could. Also, Lisa had said she's going to call President Peterson, let her know you shared her words, and I love that, the impact of the convocation talk. And then Jenny said, thank you. Judith said, thank you. Sue is so cool from Sarah. I'll be quiet in case you have any questions here. I just wanted to make sure you saw those chats.
Thank you.
I have a question. This is Courtney Rice. I am not camera ready, so I'm just going to ask my question quick, if that's okay.
Sure.
So earlier at the start of your talk, you were talking just sort of about the general struggles, and it's kind of been on my mind a lot lately, watching the news and seeing things like, you know, hospitals at an overcapacity, or this morning they were saying in, you know, Mohawk Valley region where I am, there are only 45 open hospital beds right now. And I started to kind of think like, you know, what can people like me, like in the general community who are not in those trenches, kind of do to help you guys, if anything?
Well, I don't know your region. I know that, so I'm not sure what's being recommended in your region. But, you know, I think to the best of your ability, if you're vaccinated, that certainly will help. Encouraging people that you know that are on the fence about vaccination to, you know, either have a resource, someone, a trusted healthcare provider who can talk with them about that. Wearing masks in public, social distancing, avoiding large groups and gatherings, particularly where people aren't wearing masks. You know, those are the kinds of things. I think what my husband is also in healthcare, and you know, we're still wearing our masks to the grocery store. We're still wearing masks when we're out in public. We are avoiding large gatherings inside with people. So I think sort of going back to the basics and, you know, making sure that you're vaccinated for the flu, and when you're sick, staying away from other people. So, and then I would check in. I know that in our area, the State College borough, it has mandated, we have a mask mandate in our borough. I don't know that everybody's doing that, but also supporting people who are wearing masks. I know sometimes for me, it's uncomfortable when I'm out wearing my mask because people are looking at me. And that's not hard for me to do, but I think for other people who may not be comfortable, you know, being supportive. And it always helps to feed the staff. So if you want to send pizza up to an emergency room, nobody will say no.
There it is. That's the idea. Thank you.
I love that. Lisa has her hand raised, and then we've got a few other comments in the chat also.
Great. Sue, just as always, I mean, it's so fabulous to see you and to get this update in person on the incredible work and leadership you're providing in a needed area. And your talks, you know, Sarah alluded to it, that you two became connected through developing this presentation. That's clear to me, lucky for us and lucky for our nation. But I loved your stories, the way you wove in the stories of Kelsey and Lori and John to remind us that these are very real challenges of our neighbors everywhere. And you both really spoke about it. So on my mind with your talk is that you're working uphill against huge barriers. So you're reminding us that it was worse during COVID, that many people, because of lack of access to affordable healthcare that is consistent, that has wraparound or whole person services, I think, as you were talking to me about it, and Sarah was, around social determinants of health, those are big barriers. And we can't seem, it's consistent with my question for Sarah, these are structural issues. We have to demand different. So Courtney, I love you asked what to do. Be activists. I mean, there's just stuff that's wrong, right, with the structure about costs and access and the opportunity to thrive across a lifespan. So I'm thankful, Sue, that you brought that forward. And in particular, that we don't, not that any of us here would, COVID brought a light to the issue, but the work you do in diabetes care is about foundational well-being and the absence of it or the risk level of it.
Right.
And what we have to be doing in our communities to provide connected communities that promote health in every way. So,
and I think it's a really good point, Lisa. And I think one of the things I see in rural communities is trying to deliver healthcare in clinics is not sufficient. A lot of people don't want to come into the clinics.
That's right.
You know, doing things, you know, I talked a little bit about my YMCA activities, and I think it's so important to find alternative places to provide care, screenings in fire companies. In rural communities, fire companies are social hubs. So if
That's
we're
right.
doing healthcare screenings, it's not going to be effective to open up my clinic and say, come on in, I'll check your blood pressure. But it's really going to make sense for me to make
That's
friends
right.
with the guy who is, or the gal who is in charge of that fire company and say, hey, I want to come down and talk with your people about what the risks are here. Let's face it, we have lots of them. And then I've also been here for 12 years and I come out at 7:30 in the morning and I stay until 8:30 at night. My car's the last one to leave the clinic. They all know that now.
Yes.
So, but it takes years and it takes time and it takes support from administrations in healthcare. Somebody mentioned being a healthcare administrator. We're really struggling in healthcare because there are these two competing forces pushing against us. Administrators who want to increase our efficiency and our productivity, and then also insurance companies that want to cut back on the cost of care. So
Right.
At the center of all that are the two people that are trying to do the best they can, the provider and the patient.
Yeah.
And that's where we're really struggling.
Yeah, we're fighting against a collective impact model
Mhm.
in a way that isn't productive. I love what you said, and Sarah said about paramedicine. One of the great innovations, right, came out of capacity in EMS systems, dispatch health. I'd love to talk to you at some point about what you think about that, but how one uses that. And then, although she's not speaking, I don't think, I hope she wouldn't mind. I would say that at the foundation where we work on all of these issues for people living with low income who are struggling with issues of health equity, Eliza Heppner, Sarah's wife, built some of the best systems, processes, and innovations and protocols that really help build screening tools around social determinants, helped use capacity in healthcare systems. So a call out for another session on how that works as well.
Well, and I
Thank
did
you.
work as the interim director of quality for 4 or 5 years, and I don't do that anymore.
So it's just,
I like my clinic a lot better.
yeah.
I'm happy to have that talk too. So anytime we're ready.
Yes. What you do is a lot. Thank you, Sue.
I learned how to do that at Wells, Lisa.
Lucky for us.
Lucky for me.
When am I going to learn about the mute? Well, does anybody else have any questions or comments for Sue or Sarah? These we're pretty good at talking. Lisa, your hand's still up, but I think that's from before. Okay, I didn't know if you had another question. Okay, well, if anybody wants to get in contact with Sarah or Sue, just send us an email, like I said before, alumoffice@wells.edu, or give us a call. I'm so grateful to you two for being here tonight. I've been so excited for it, and we've met a few times, and every time I get off the calls with a big smile on my face, even though it's about not exciting news developments usually, but just to be around Wells alums doing wonderful work. I'm going to get this up on the YouTube page in the next day or two. So feel free to send people there. And like I said, reach out if I can connect you, especially our students. I would love if we can get some internships this way, or just make connections with one another. And thank you both so much for being here. And thank you all for coming. And I look forward to seeing you. Thanks, Jenny. I look forward to seeing you all in January. We've got Rhea Hirschman from 68. She'll be doing a talk about women in suffrage. And I don't have the whole line yet about what she's talking about exactly, but that's the basics. It's on the second Wednesday of the next month at 7:30. So I hope to see you all soon. Have happy holidays and have a great night.
Thank you.
Thank you so much, everyone.
Thanks, everyone.
Bye.